All right, my clock says it is 12 o'clock. Good afternoon, everybody. I'm Corey Hill. I work at the Partnership for People with Disabilities at Virginia Commonwealth University. And I'd like to welcome everybody to the September Talks on Tuesday. As a reminder, this is part one of a two-part series. So I'm glad you all can join us. I'm delighted to welcome our two presenters, Kelly Walsh-Hill and Charlene Stowers, and I'm actually going to let them introduce themselves. So Kelly, would you like to start first, please?
Sure, Corey. Thank you very much. Hi, everyone. I'm Kelly Hill. I've worked in pediatric therapy for 33 years and currently work as a provider in both NICU and early intervention. I'm also chair of the Virginia Interagency Coordinating Council. I've done webinars in the past for early intervention providers in coding, billing, and documentation, but these days my focus has been on promoting family-centered care concepts. I participated in the statewide NICU EI initiative, conducting trainings to improve family-centered care in the NICU and improve the transition from hospital to early intervention. More recently, I've been working at my local level to establish interagency family-centered care for our babies with NAS and their families. And I had the honor of presenting at the National Perinatal Association's annual conference on perinatal substance use and NAS at Loma Linda University in March of this year. And I'm happy to be sharing the floor today with Charlene Stowers.
Thanks, Kelly. And boy, she's a tough act to follow. I'm Charlene Stowers, Director of Early Intervention for Grafton Integrated Health Network and the local system manager for the Infant and Toddler Connection of Shenandoah Valley. I've assisted in webinars way in the past, and I've also presented at the Grafton Symposium on the effects of trauma on infants and toddlers. And I also had the privilege to present at the Shining Stars Conference on the substance-exposed infant, the next generation. I've participated in the statewide NICU and EI initiative along with Kelly, and was also part of Virginia's Handle with Care initiative. I'm also happy to have the chance to work with Kelly on this important webinar, and I'm going to pass this back to Kelly so we can begin.
Next slide, please. So in part one, Charlene and I hope to increase your awareness of the national and local opioid crisis, understand substance use disorders and the stigma associated with pregnancy, understand the impact of drugs on fetal development and how neonatal abstinence syndrome is diagnosed and the methods of treatment, and the Virginia state recommendations on supporting these babies and their families. Next. In part two, in October, we'll be talking about creating an awareness of how toxic stress affects the mother-infant dyad, understand family-centered care concepts, provide some guidance in developmental assessment and treatment of the baby with neonatal abstinence syndrome, and engage early intervention programs to look at their protocols to ensure they're meeting the needs of this unique population. Next. We'll be using some acronyms and terminology today that you may not be familiar with, so you may want to have handout number 1 handy to use as a reference. This was sent to you prior to the conference. And as we talk, the relevance of these terms will become more clear to you. Next. So how many of you out there have had an illness, injury, or surgery where a doctor prescribed some pain medication afterwards? Please raise your hand.
So as a reminder, if you just joined us, the raise your hand feature is right under your name. Kelly, we have lots of hands popping up all over of people who have experienced this.
All right. Well, you probably didn't think much about what you were taking as long as it helped, right? You may even be familiar with brand names such as Percocet, Demerol, Vicodin, or Tylenol 3s. Next. But did you know you were taking an opiate? Did your doctor explain the potential risk of addiction? Take a look here and see all of the chemical compounds derived fully or partially from opium, that pretty little flower. When you hear about the opioid crisis, how many of you think heroin addict? Most of us do because that's what we see and hear about in the media. But did you know between 1995 and 2015, the number of prescriptions prescribed to women for pain management tripled? Next. Now let's play a matching game and see if you can connect the brand name in the middle to the chemical compound that it is associated with. If you don't know, don't worry, just take a stab at it. Go ahead and take your pencil and draw a line.
So as a reminder again, for this one you're using the third tool down on your little toolbar. And Kelly, we have lots of people connecting so far the marijuana leaf with THC, nicotine, codeine with Tylenol 3. Some others have not been hit yet, Kelly. They're oxycodone with Vicodin. People are still working. I'll tell you when it slows down a little bit, Kelly.
Sure.
So it looks like people are most aware of the ones that I mentioned, the marijuana, codeine, and Tylenol 3, and nicotine to the cigarettes. All right, nice job, everybody. Kelly, I'll go ahead and switch to the next slide.
Sounds good. So here are the actual connections. I know most people got the THC with the marijuana leaf and the nicotine with the pack of cigarettes. Maybe some of you were able to hook up Vicodin with hydrocodone, Tylenol 3s with codeine, Percocets with oxycodone. I think that sometimes surprises people. Dilaudid into the hydromorphone family, and Demerol in the meperidine family. When you look at the vast array of drugs here, it's really hard to know what you might be taking, isn't it? Next slide. So let me tell you about one of my clients. Carly is a 38-year-old mother of 3. She was in a car accident in 2012 that broke her back in 2 places. She spent 3 years recovering from 2 major surgeries and months of rehab. Her doctor gave her Tylenol 3s to help manage her pain during that time. He never told her they were addictive, even as she developed a tolerance and kept needing a more frequent dose. And then one day, when her rehab was all over, he told her he couldn't write her any more prescriptions. She said okay and went home, and when her pills ran out, she quickly realized she was addicted. No one would help her, and she was ashamed and afraid, especially when she gave birth to her 3rd child in 2016, and that baby went through withdrawal from codeine. Having a substance use disorder doesn't always mean you're a heroin addict, and that's why we have a crisis. Charlene?
Thanks, Kelly. Have you ever thought, why don't they just quit? Don't they care about their baby? Raise your hand if at any point in time you've had those thoughts cross your mind when working with these families. I'll be honest and admit that I used to have that same mindset. It would frustrate me as I saw the number of referrals for substance-exposed infants increase, and I found myself becoming very judgmental. It wasn't until I started to learn that addiction is a disease and began to reframe my thoughts that way that I was able to open my mind to accept that people don't choose to have this. People don't choose to have things like major depression or bipolar disorder or other chronic illnesses like diabetes or asthma or cancer, and they don't choose to become addicted to drugs. Kelly did a great job providing an introductory overview of the various substances our babies are often exposed to. As we planned these 2 webinars, we felt that it was important to give information on what is a substance use disorder. After all, how can you expect to help a mother or the family if you don't have an understanding of what they are dealing with or going through? The term substance use disorder is now used in place of substance abuse and substance dependence. A substance use disorder can be mild, moderate, or severe depending on the number of diagnostic criteria met. The most common substance use disorders are tobacco and alcohol, which is not surprising to any of us, and there's also a lot of research behind these substances. But there is also cannabis, stimulants, hallucinogens, and opioid substance use disorders. Interestingly, cannabis is the most used drug after tobacco and alcohol. And I'm sure that doesn't surprise any of us, given the push to legalize marijuana in many states. However, I will say just from personal experience, anecdotally in our program, that while it may not be legalized in Virginia, about 70% of the referrals to our system include marijuana, either alone or in conjunction with another substance use. Brain imaging studies actually show physical changes in the brain for people addicted to drugs. In this picture, you can see what a healthy brain looks like. The normal healthy brain, drug-free at age 16. Thank you, Corey. You can also see pictures of other brains exposed to other substances over a period of time, such as marijuana at the age of 16 over 2 years of time, smoking after 3 years of smoking when you start at age 16, the use of inhalants after 6 years of use, cocaine after 3 years of use, meth after 3 years of use, and 4 years of use of alcohol. You can see that the changes are not only chemical, the substance use does not only change your chemical composition in your brain, but it also changes the physical composition, giving the brain kind of a cottage cheese or Swiss cheese appearance. It is true that the initial decision to take drugs is a choice, but when addiction takes over, the body's ability to have self-control is reduced. All drugs used, like nicotine, cocaine, marijuana, and others, affect the brain's reward circuit, which is part of the limbic system. Drugs hijack the reward system, causing unusually high amounts of dopamine to flood the system. This flood of dopamine is what causes that high or euphoric feeling associated with drug use. When the reward system is overstimulated and that euphoric effect is produced, people want to continue seeking this. We all experience this phenomenon, even without the use of a substance. For me, it's the experience of a massage. I know when I go get a massage, I feel relaxed, I feel calm, I feel peaceful, I feel energized, and as soon as that massage stops, my brain is telling me, schedule that next appointment, you want more of this. So we all can relate to what that feeling is like. As a chronic brain disease, the brain responds more to drug cues of wanting more drugs instead of regular cues most people experience that make them feel good. This also leads to an increased sensitivity to stress, and the person has less ability to self-regulate. So as a result, they fall back on drugs because that's what helps them feel or function pain-free or normal. We tend to view addictions as a hopeless issue instead of a treatable chronic disease that can be managed. For people living with a substance use disorder and their families, it's a roller coaster ride with ups and downs and twists and turns until the disease is treated. But it is treatable. However, that does not mean that it's cured, and people will often have setbacks. As you can see, relapse or the occurrence of the past condition is real. For someone with substance use disorder, the relapse rate is similar to people with other chronic illnesses. For instance, some substance use disorder relapse is 40 to 60%. Those with hypertension is 50 to 70%. With asthma, it's also 50 to 70%. Yet these conditions tend not to have the same social stigma attached to them.
Charlene, I'm going to jump in for just a minute before you do the poll because I forgot to tell people how to do this, and then you can give the directions. So if you would like to participate in the poll when Charlene gives you the directions, I want to be sure that you can see right under your name, next to where you raised your hand, the fourth box over from the left, there is a little box, and it has a drop down with yes or no, and that's how you'll be able to participate to vote in the poll. Thanks, Charlene.
Thanks, Corey. So my question is, mothers should stop taking opioid drugs when they find out they are pregnant. So using the polling, answer yes or no, please. We'll give everyone a few more seconds to make their selection, and then Jeannie or Corey will show the results.
I can see that some people are participating. Just in case you need directions again, it's right under your name, and it's the fourth box over from the left, and it has a drop down that you can either check the green for yes or the red X for no.
Okay, thank you. Mothers should actually not stop taking opioid drugs when they find out they are pregnant. This is because the immediate cessation of taking those drugs can cause further complications for the mom or the baby. So what really is known and not known about substance use disorder in pregnant women? There is a lot of evidence about the harmful effects of tobacco and alcohol use while pregnant, but there isn't as much evidence out there about other substances. We do know that drugs cross the placenta at various stages of development, and we know that it can affect blood flow and nutrition to the fetus. But getting stronger evidence is challenging. After all, you can't really ask a woman to take drugs when pregnant just for a study. And when drug use is known, it's very hard to attribute outcomes to a specific drug since most use multiple substances. Also, other factors like poor nutrition, poverty, abuse, and limited prenatal care can play a part. So while there are still a lot of gray areas in regards to substance exposure, research shows that certain types of drugs, including heroin, opioids, do have adverse effects on birth or shortly after, and these babies may experience neonatal abstinence syndrome. Kelly, will you share with everyone what you have learned about neonatal abstinence syndrome, particularly in regards to Virginia?
Sure, Charlene, and thank you for that great explanation and understanding of substance use disorder. So what is happening here in Virginia? Well, between 2016 and 2017, Virginia saw an 11% increase statewide in NAS hospitalizations, even though the overall number of births in the state declined. By this graph, you see we went from 741 to 819 cases in 1 year. But it's important to know that NAS is not new. A condition known as congenital morphinism was identified in the early 20th century during a time when many pregnant women were prescribed morphine for a condition called hysteria. It was renamed neonatal abstinence syndrome in 1965 when recreational drug use increased and heroin emerged. Methadone was used to treat the addiction, and babies were noted to withdraw from methadone. But the overall incidence of NAS remained low compared to the total number of births nationwide. However, between 1995 and 2009, opioid prescriptions for pain management in pregnant mothers doubled. And by 2012, every community in every state was facing an NAS epidemic. In my little town of Warrenton, we had 6 cases in 2015, and this jumped to 19 cases in 2016, and now we have close to 30 cases annually. Next. Jeannie, if you can help me use the pointer with this, I just want to show everyone that at the breakdown by region, we can see a significant 31% increase in the incidence of NAS in the Southwest, and increases in both the northwestern and central parts of the state. It's probably not a coincidence that these areas border Tennessee, Kentucky, and West Virginia, states that we know have a high opioid problem. When you see the lower incidence in the north and the east, it's important to understand that up until this year, not all hospitals across the state were following any specific protocol to identify substance exposure or assess babies for NAS. However, with the new statewide initiative that started this year, there's an increased expectation of consistent protocols being followed now that Virginia has signed on to participate in the VAUGHN program. The Vermont-Oxford Network is a nonprofit collaboration of healthcare professionals dedicated to establishing a community of practice for newborn infants and their families through a program of data-driven quality improvement, education, and research. And they have been the leaders worldwide in establishing best practice protocols for NAS. Next. So again, what can happen when a baby is substance exposed utero? Jeannie, I'll need your help with the pointer here. What are the potential effects on birth and pregnancy outcomes? Looking at the 4 major drug categories, we have tobacco, marijuana, opiates, and stimulants like cocaine and methamphetamine. So this is what we know. Tobacco and stimulants and opiates can cause prematurity and a condition called IUGR, or intrauterine growth retardation. And this is where the baby has low birth weight and decreased birth length and decreased head circumference based on their gestational age. Additionally, tobacco and opiates are associated with an increased risk of SIDS and a higher infant mortality rate. Stimulants can cause intraventricular hemorrhage, and opiates, as we know, can cause NAS. Interestingly, marijuana has no documented effect on fetal growth and no correlation to fetal abnormalities. But just because the effects of exposure aren't seen during the pregnancy or at birth, it doesn't mean that the baby won't have developmental challenges. Next slide. So what's happening to the fetus during gestational development when they get exposed to these substances? Because of the low molecular weight and lipid solubility, drugs pass easily from mother to fetus through the umbilical cord. The active metabolites of the drug enter the central nervous system of the fetus during a time of rapid neuronal cell production, causing cell injury and possibly cell death. We also know that the side effects of certain drugs can cause vasoconstriction and decreased blood supply. Remember, stimulants are associated with IVH. Because oxidation is not fully developed and renal function is immature, the drugs tend to accumulate in the baby's adipose tissue and developing organs. And because of the differences in metabolism, the half-life of opiates is much longer in the fetus compared to the mother. Next slide. It's important to recognize that it is infrequent to have a baby exposed to just one substance. These are some of the common drugs babies will also test positive for, along with the opioids or stimulants. Nicotine and THC or marijuana are number 1. but also we see SSRIs, and this stands for serotonin-specific reuptake inhibitors. These are the drugs used to treat depression and anxiety. So we see positive test results for things like Celexa, Wellbutrin, Zoloft, and Lexapro. We also see antipsychotic drugs like Lamictal and Latuda, which are used to treat bipolar disorder. Even too much caffeine can have an impact on withdrawal if mom is a heavy soda or coffee drinker. We call this the cocktail exposure. So it's not just the type and intensity of the drug exposure, but the combinations of drugs that can complicate withdrawal. If you think about the prenatal effects of substance exposure and the vast array of drug choices and combinations, you can imagine the challenge treating NAS. So the preferred method of management during pregnancy is having mom in a medically assisted treatment program. Next. Why does MAT matter? First and foremost, when the obstetrician knows what mom is taking and how much she's taking daily, they can monitor the pregnancy more effectively and provide prenatal counseling. Going off drugs while you're pregnant is not recommended. The two most common MAT drugs are methadone and Subutex. Babies are still likely to experience NAS, but we know that methadone doesn't affect fetal growth and it doesn't cause birth abnormalities. On Subutex, the baby can have less severe NAS symptoms and it's compatible with breastfeeding. A recent study comparing methadone to Subutex didn't show a difference in the incidence of NAS, but it did show that babies exposed to buprenorphine, which is the Subutex, required 86% less morphine to treat their NAS symptoms. They spent 43% less time in the hospital and 58% less time being medicated for NAS. So if moms can use Subutex over methadone, that would be preferred. Next. What is neonatal abstinence syndrome? It's a generalized disorder of four systems at birth interfering with state regulation. In the central nervous system, the symptoms we see are irritability, a high-pitched cry, sleep problems, increased muscle tone, tremors, and hyperactive reflexes. This is evident in the picture in the upper left-hand corner, and also you see the tremors and the hyperactive reflexes in the lower left-hand corner. The respiratory symptoms are tachypnea, nasal stuffiness, and excessive secretions or spitting. Autonomic symptoms are sweating, sneezing, yawning, and hyperthermia. These babies run hot. And then we see GI symptoms like dysrhythmic sucking and swallowing, regurgitation, poor intake resulting in weight loss, and loose stools. You see a classic picture in the upper right-hand corner there of a baby sucking very nicely on a pacifier, but not able to coordinate that sucking reflex with the swallow. So we've had to put an NG tube into the baby's nose in order to give him or her nutrition. You can also tell by the posture of that baby with his arms out to the side and kind of raised up that he's probably breathing very rapidly and fast, and also probably see some increased tone. And in the lower right-hand picture, you see a baby giving a big yawn there with some loose stools. All of these pictures are classic pictures of babies going through NAS. Next slide. So again, we're going to use that polling tool to answer yes or no to this question. Babies who go through withdrawal at birth are addicted.
So as a reminder, you're going to use the same tool that you used last time, fourth from the left, and you can answer yes or no. Kelly, I'll give you a clue when people are kind of finished as I'm watching them.
Sounds good, thanks.
All right, Jeannie, if you could pull poll, please. So Kelly, we had 19% said no, 31% said yes, and 48% abstained from voting.
Okay, so let's go to the next slide.
Kelly, as you go to the next slide, we have had a question. Roughly how long does how long do the symptoms last, especially related to emotional regulation?
It's really different for every baby because we not only have that cocktail exposure that I talked about before, but also all the other comorbidity factors, like if that baby was born preterm or IUGR, that can complicate things. So it really is the initial withdrawal period fluctuates anywhere from 21 days to, as long as 36 days. But we also know that some of those self-regulation symptoms will actually continue to be seen in a baby as long as 3 to 6 months after birth.
Thanks, Kelly. And I am on the NAS is not addiction slide now.
Thanks, Corey. So NAS is not the same as addiction. To call babies addicts is stigmatizing and incorrect. They are passive recipients of the drug and do not have compulsive drug-seeking behavior in spite of adverse consequences. What they have is a transient but potentially serious physiologic disturbance that results from that sudden discontinuation of the opioid exposure once the umbilical cord is cut. Next slide. So what is the treatment protocol for NAS? The treatment protocol, as recommended by the Vermont-Oxford Network, is to identify the mother with a substance use disorder as early as possible. This can be acquired through obstetrical history taking or toxicology. Universal toxicology involves collecting and testing urine in all moms at the time of birth, and this is done with informed consent. If mom tests positive, then the baby's urine, cord blood, and meconium is collected. Urine is not always reliable, so the cord and meconium are sent out for further testing. Meconium, which is fetal waste that begins collecting in the digestive tract starting at gestational week 12 to 16, is the most accurate. It's going to show what that baby ingested going back to the start of the second trimester. If mom refuses to give a urine sample, in Virginia, the doctor may still order cord and meconium testing if he or she suspects substance exposure based on a clinical exam. The baby is then admitted for a minimum 5-day stay for observation, and NAS scoring is started. Sometimes NAS symptoms don't peak until 36 to 72 hours of life, so it's important not to send them home too soon. Next slide, please. Most hospitals use the Finnegan scoring tool as a way to quantify the severity of symptoms. Every 2 to 3 hours, the nurse will assess the baby in the room with the mom. The baby's scored for items like those symptoms that we talked about before: poor feeding, tremors, increased tone, excessive suck, irritability, poor sleep, loose stool, or increased temperature. The scores are totaled, and if it stays below 8, mom is taught how to care for her baby using a non-pharmacological approach that we'll talk more about in a minute. If the baby has 3 consecutive scores over 8, or for example 2 scores over 12, medication will be started. In other words, any total of 24 after 2 to 3 consecutive scoring episodes warrants adding a pharmacological approach. In most cases, the baby is then admitted to the special care nursery or NICU because they require closer monitoring once on medication. Once we reach a dose that calms the baby down, we hold at that dose for 24 hours. If the scores remain low, we consider them captured. Captured simply means that we've had a sustained period of time where the baby is maintaining low scores and beginning to eat and sleep. There's another assessment criteria being piloted right now in some hospitals called Eat, Sleep, and Console. And it looks at timed parameters for that baby's ability to eat, how long they are sleeping, and how long it takes to console them once they're upset. It uses this as a way to determine if medication should be introduced and also to determine when the baby should be discharged. Some argue that this is too simplistic, but others feel it's less subjective than the Finnegan scoring tool and maybe gets babies home sooner. But this is fairly new, so we're going to have to look at data in another year or two as both methods are compared. Next slide, please.
Kelly, we do have a question. What would the doctor see that would lead to the decision for universal toxicology testing?
Well, sometimes this is actually looked at in the delivery room in consultation with the obstetrician. If mom has obvious track marks or areas where it looks like she has been using some needle injections, then it can be determined at that point in time, even if mom refuses a urine screen, they can test the baby. If the baby is born with suspected symptomatology such as IUGR, and if the baby is very jittery, if the baby has any kind of respiratory distress right at birth, or is having a lot of trouble regulating their temperature, those would be some very early signs that there might be a problem. And even if they miss the first urine of the baby, they can go back later and collect the cord and meconium, especially meconium, because babies often don't pass that until quite a few hours after birth. So even sometimes they're able to see some symptoms such as the tachypnea, which is rapid shallow breathing, or a baby's inability to latch onto a pacifier or a nipple is also can sometimes be one of those very early signs. And also a lot of yawning and sneezing. All those autonomic systems are very telltale.
Thanks, Kelly. I have gone ahead now and switched the slides, so we are on the polling yes and no question slide.
Alrighty, so we're going to go ahead and here you want to do use your drawing tool, and to answer yes or no, the first question or statement rather is some babies who test positive for drugs at birth don't go through withdrawal. So please mark yes or no if you agree or don't agree, and then also to the next one, which is mothers who test positive for drugs should formula feed instead of breastfeed their baby.
So Kelly, people are still putting their answers. I'll give you a sign in just a second as I see people are finished drawing. Okay, so for the first question, some babies who test positive for drugs, everybody has checked the yes box. Nobody responded no. And for
so everybody gets A+ on that one.
Okay. And for the second question, it is a mixed result, more responses in no, but some yeses.
And I would say that that's probably a good demonstration of what most of us kind of think, and what I will share with you is that in many cases the answer is no, and I'm going to explain why in just a second. So if we can move on to the next slide, we're going to talk about what is non-pharmacological care. And this is one of the very first things we can do when we know a baby's been exposed or suspected. We start by creating a low stimulation environment right after birth, meaning low light and low sound, right in the mother's room. We teach parents how to swaddle and contain their babies to prevent overstimulation. We emphasize allowing the baby to suck on a pacifier because this is their only way to self-soothe. We promote sleep by limiting handling among staff and visitors. Parents and caregivers are taught how to read the early stress cues, such as yawning and sneezing, because we want them to intervene before the stress escalates. We want to keep those scores low. Once agitated, it takes a lot more intervention to calm these babies down. If the baby's rooming in with mom, skin-to-skin holding is encouraged, like you see in the left lower hand picture there. And if the doctor okays it and mom wants to try, breastfeeding is also encouraged. Tests show that less than 1% of methadone or Subutex transfers to breast milk, and the American Academy of Pediatricians recommends that as long as the mother is in a treatment program, she should be allowed to breastfeed. Breastfeeding is not indicated for moms who are HIV positive, on a contraindicated medication like some antipsychotics, or are active drug users not in a treatment program. Some babies may test positive for substance exposure, like cocaine, but not go through withdrawal or have minimal symptoms. And this is often the case for stimulants because they have a very short half-life. And although these babies may not experience withdrawal, they may have other comorbidities like prematurity and or IUGR. So the take-home here is that even though the baby doesn't go through withdrawal, it doesn't mean they aren't going to have developmental challenges. Next slide. If the baby requires medication, morphine is typically the first-line drug, but there are some variations in what hospitals are using, and some start with clonidine. They're started on a low dose that's given every 3 hours. If the baby remains agitated, unable to sleep and eat, and has high scores, then the dosage is increased. As I explained before, once that baby is captured with low scores over 24 hours, we'll immediately start to wean the morphine daily but slowly. NAS scoring continues all throughout the weaning stage because sometimes symptoms reemerge, and then we have to hold the weaning for a day until the baby has time to adjust. If the morphine dose is at the max based on the baby's weight and they still aren't captured, then a second-line drug can be added. I do know that some hospitals are using methadone, but I learned in Loma Linda that pharmacists feel that the way this drug is metabolized by the body, especially the baby's body, it typically isn't recommended to be a first-line drug. Next slide. So clinically, we know how to treat babies with NAS, but for many, it isn't a quick recovery. As these babies are healing from NAS, we are always working towards physiological state regulation, that ability to unconsciously manage your heart rate, respiratory rate, and body temperature. These babies struggle with achieving and maintaining that ability, and they can go from 0 to 60 pretty quickly, even with a simple diaper change. A newborn's ability to achieve homeostasis when all of our body systems are in sync is critical for healthy cell production and function. It's only then that efficient sensory processing and neurodevelopment can happen. Next. But the baby with NAS can't get there alone. We now know that the critical component to this healing process is the mother. And Charlene's going to give us some more information about that mother-infant dyad now.
So using your polling option again, take a moment to answer this question. Mothers who test positive for drugs at birth are committing a crime. Or do you want, or Jeannie, do you want to show the results so far? So it looks like most of you selected no as the answer to that, whereas actually in the state of Virginia, it is considered a crime, it is considered child abuse for mothers who are using drugs while they are pregnant. Most policies written to address substance use among pregnant women assume that all substances used during pregnancy are harmful, and as a result, harsh penalties are written. Despite evidence that punishing pregnant women for drug use is detrimental to maternal health and Fetus Health, 24 states classify substance use during pregnancy as child abuse under civil child welfare laws, and Virginia is one of those 24 states. The Child Abuse Prevention and Treatment Act, or CAPTA, requires states to have policies and procedures in place to notify CPS of substance-exposed infants and to establish plans of safe care. Virginia does include a substance exposure in the definition of child abuse and neglect and has specific reporting procedures for these infants. That said, there is more support of addressing the issue of drug use among pregnant women as a public health issue versus a criminal act. The reason being is that harsh policies further promote the stigma and fear of consequences that many women may not seek proper prenatal care or even effective substance use disorder treatment if appropriate. Virginia's response has been through the Handle with Care initiative, and it came about over growing concerns regarding the difficulties across systems in meeting the needs of pregnant women who use drugs and their children. The Department of Behavioral Health and DBHDS applied for substance-exposed infants in-depth technical assistance from the National Center of Substance Abuse and Child Welfare in 2014, and were able to receive that technical assistance through August 2016. And the goals of this were to increase collaboration among systems to look at state laws and their effectiveness with prenatal substance use, as well as to identify any changes in regards to the implementation, and to put in place a system of care that would ensure that all women of childbearing age would have screening, brief intervention, and access to behavioral health treatment. Clicker's not working.
I got it, Charlene. There you go.
Thanks, Corey. The statewide system of care looks at strengthening community collaborations, strengthening legal reporting requirements, providing individual and family support, and increasing treatment options and access. The plan of safe care is meant to identify the strengths and the supports needed by the mother, and is meant to include the needs of her children up and through their teen years. Substance use disorder is many more times prevalent in people with, if you'd like to answer this question, substance use disorder is how many more times prevalent in people with post-traumatic stress disorder than those without.
Okay, so for this one, Charlene, am I right? You'd like them to go ahead and take a guess on this one?
Yes.
Okay, so you're going to use your polling feature again, the little A under your name, and do you think it is 1 to 2 times, 3 to 4, or 5 to 8 times more prevalent? Okay, Jeannie, can you go ahead and pull the poll, please? There you go, Charlene.
Okay, thank you. And yes, it is 3 to 4 times more prevalent in people with substance use disorder. And in essence of time, I'm going to go ahead and give everyone the answer for this next slide. What percentage of women with substance use disorder have studies found to have post-traumatic stress disorder? And that is 30 to 59%. And that's compared to approximately 11% of what it is in women in the general population. That's a very significant amount. We know that pregnant women with substance use disorder feel stigmatized and judged, and they feel guilt and shame. And I've read many discharge reports that indicate that the mothers never shared her addiction with family members or even the father of the baby. Pregnant women often feel the risk of losing their custody of their children, They also may be in unhealthy relationships and fear that seeking help will result in further abuse. They may be self-medicating just to deal with their own stressors and mental health issues. And sometimes I see in reports that the mother chose to smoke marijuana because she felt that it would be safer for her baby than a prescribed antidepressant. Drugs and mental health affect the same parts of the brain, and studies have shown that between 1/3 and 2/3 of women diagnosed with substance use disorder have experienced childhood physical or sexual abuse. There's been a lot of attention lately to the ACEs study and how trauma in childhood affects the overall health and welfare in adulthood. Toxic stress is real. Toxic stress, the effect on body and mind when under stressful conditions for an extended period of time without a support network or other social buffer. These chronic stressful situations, if not addressed, become toxic to the body and lead to many physical, mental, and emotional problems. This is real to a mom with substance use disorder. She may be using the drugs to manage stress in her life. Research shows a strong link between toxic stress and drug use. Toxic stress may also contribute to other health issues that may affect the baby. And toxic stress experienced prior to a woman becoming pregnant has also been linked to preterm birth, low birth weight, and other developmental issues for children. As we move forward in looking at the family-centered care for substance-exposed infants, we need to be aware of the stressors and be able to work with the families to reduce the stressors and the consequences. This is why we look towards part 2 of the webinar. We want to look at recognizing that nothing occurs in isolation, that education, healing, and treatment of the substance-exposed infants, and I'm also going to add substance-exposed toddlers, is about more than addressing just what the baby needs. As these babies come to us, we need to be prepared to look at the relationship between the mother and the caregiver, the entire dyad, to be able to educate the family on what to expect and how their experiences can affect the development of their baby. This can often be an uncomfortable discussion to have. So where do we go from here? We've shared a lot of information with you in the last hour. And as we prepared these 2 webinars, Kelly and I struggled with how to separate and then tie all the information back together. So we're hoping that we were able to do that today because we finally determined that it was best to start with some of the basic knowledge of the issues before trying to engage everyone with the next steps. In our next webinar, Kelly and I will share with you ideas of approaching challenges of working with substance-exposed infants and their families from a family-centered concept of care through program approaches also at the local level. We welcome any questions or comments right now, and thank you all for joining us today. And I'm going to turn this back over to Kelly.
So Kelly, this is Corey. Kelly, right now we have the slide up for people to ask any questions, so I'll help you monitor that in chat. If you do have questions, please feel free to type those in chat, and I will be sure that Charlene and Kelly are able to see those. You will see that Jeannie has written a note in chat that our next webinar, which is part 2, is on October 2nd. And Kelly, I'm going to wait just a moment because I can see several people are typing. Here's the first question from Carrie. What is the source of the pictures of the different brains you showed early in the session? Charlene, that was the slide you shared. So perhaps you might be able to
do that slide. Actually, I found it on Google, and I will need, at the top of my fingertips, I don't have that exact source, but I can find that and we can send that out, share that information with everyone.
Stephanie has asked, could you please repeat what IUGR stands for?
Yes, it is Intrauterine Growth Retardation, and that is one of the acronyms included on your handout 1, and it is where we have decreased length, decreased weight, and decreased head circumference based on the gestational age of the baby. And it is sometimes referred to also as small for gestational age.
Thanks, Kelly. Carrie, you'll notice that Jeannie has put the source for the brain picture in the chat. So if you're not able to see that, let us know. Just scroll up a little bit in your chat and you can find the URL. Kelly and Charlene, Danville, Pennsylvania asked, is there any research that tells you the likelihood of them becoming addicts as adults?
I think what you would want to look at to answer that question is the information that's being provided now in the ACEs study, in that how, the stressors, the trauma, what these children might be experiencing now and how that may affect them as their own mental health as they grow into adults. So, if you Google the ACEs study, it goes into great detail regarding experiences that children have and how that impacts their own health and mental health later on down the road. So that's the best resource that I know of.
And I would agree with Charlene. Most of what they're showing nowadays is it's still the environment that these children are going to be raised in that is more indicative of their later drug use than being exposed at birth.
Right. Nicely said, Kelly.
And I see a question from the ITC of Goochland Powhatan. Why is it that moms should stop taking opiates when they find out they're pregnant?
Kelly?
Sure. If a mother were to suddenly stop taking the opiates, then she would likely cause an increased risk in her own health, as well as cause a very high risk of fetal death almost immediately, because the baby would be actually cut off from that exposure right away. So from that medical standpoint and that blood-to-blood connection that the mom and the baby share, it's just considered much too dangerous.
Thanks. Thank you. I see one more question, and again, if you have any more questions, feel free. I'm monitoring in chat, but Abby would like to know, would states that have legalized marijuana call CPS for children that are positive for withdrawal?
Well, all states have laws written a little differently regarding this, and so I can't speak to every single state. However, I will say that first, even though that each state may have marijuana legalized in different capacity, it's still a federal offense. And it is still not okay for children to be exposed to it or test positive for it. And we are also finding more toddlers coming to us who have tested positive for marijuana and sometimes cocaine, but more frequently marijuana. So I can say for the state of Virginia that yes, it would warrant a call to CPS.
Thanks, Charlene. And I see that we're almost at the end of the time. Kelly, in just a second, I'm going to switch the slide for you to wrap up. Just a reminder, you will receive a survey at the end of the Talks on Tuesday, and if you complete the survey, you will get a certificate of participation. And Kelly, can you wrap us up and tell us what to be prepared for next month?
Sure. So everyone, we look forward to seeing you on October the 2nd. Charlene and I will be increasing awareness of how toxic stress affects the mother infant dyad, talking about family center care concepts and providing some guidance in developmental assessment and treatment of the baby with neonatal abstinence syndrome. and engaging early intervention programs to look at their protocols to ensure they're meeting the needs of this unique population. So we'll really be digging deep into what happens after that hospitalization.
Thanks, Kelly. A final reminder, if you registered for today's Talks on Tuesday, you are automatically registered for the October one. If you have colleagues who might be interested, this archived version of today will be available very soon, maybe even this afternoon. They could watch that, and then if they would like to register for the October 2nd, they are welcome to do that. So I want to especially thank Kelly and Charlene for all of this valuable information. I'd like to thank all of you for participating, and we hope to see you on October 2nd. Thanks, everybody, and have a good afternoon. Bye-bye.